Please. Thank you. Um, so good morning, everybody. Good afternoon in some places, and even good evening for Tony. Thank you for joining us today for our Monty Hardcast conference on a Thursday. We put an extra conference this week because we really wanted to finish part two of the nuts and bolts of FFR and IFR. So if those of you remember, we did part one with Dr. Wijns just over a month ago, where we really looked at the clinical data for FFR and IFR. And today we really want to now go into how we use it and apply it in specific patient and lesion subsets. So I'll moderate the questions with Tony Vo from Australia. And what we thought would be a good format today is that if there are questions, as we see the cases, to maybe pose your questions so we can address them at the end of each case. So William and Mattia, thank you so much for doing this for us. Your last presentation was such a hit and people keep watching it on our YouTube channel. And we really appreciate you doing it again.
With the greatest pleasure. Thank you very much, Azim and Tony for hosting us. So I'm going to do this together with Mattia, who is a postdoc, interventional cardiologist, fellow, so to speak, from Verona, who joined us in Galway just a few weeks ago. I'm trying to advance the slide. These are my disclosures. Now, the list of topics or clinical situations that either refer to a specific patient population or specific lesions, this is the list. It is your list, right? It is a long list of situations where you had questions on how to use it and what's the interpretation. Very ambitious. If we cannot, deal with all of it in 45 minutes, which is very, very unlikely that we'll be able to do so, we can always, all the slides will be available, and we're happy to have a conversation via social media or emails. So the way we'll do it, we'll alternate between Mattia and myself, and one will play the role of the fellow, the other one will play the role of the quote-unquote more experienced person, and we'll alternate these roles. And as Azim told us, happy for you to come up with questions. I know that you're addressing some of the questions via the chat online, Tony and Azim, but if some of them you want us to address, we can of course do that immediately. So let's start with the first topic that you selected. And when I saw it, I said, that's not what I want to talk about. It's very academic. Yeah, we wanted to do something pragmatic, but there is value to it. And the value is to convince us that from simple pressure, you can learn so much about flow. And that's like magic. So there is value in trying to validate it. And the standard for validation of flow as a research tool is positron emission tomography. So before looking at what's available, what are the questions or the issues we have when you're trying to address a pressure-derived index, be it FFR or IFR, and a quantitative measurement of flow by positron emission tomography? First of all, we're looking at two variables with totally different dimensions. FFR is a ratio of pressures, no dimension, and PET gives you absolute flow in mLs per minute per gram of tissue. The FFR is measured in an artery, and we don't know exactly what is the distribution volume of that artery on the PET images, which is the part of the image that is actually deserved by that stenotic vessel. PET also incorporates everything. Of course, the epicardial conductance, but also any obstacle to flow, whether it's intramyocardial or on the venous side, okay? And of course, the pressure-derived indices are focusing on the epicardial part of the picture. And finally, in any study that you do, you will have your patient in the cath lab, and several days before or after you'll do the PET examination. So it's not simultaneous and you can expect variation there. So what has been done is two studies, basically, only two studies. This is an old one. It's the very first one. And the way we try to solve the issue is as follows. We measure, these are all patients with LAD stenosis. Their FFR values are on the A box, okay, with the threshold. So the vertical axis is the relative flow reserve from PET. What is relative flow reserve? It is the maximum hyperemic flow in the area of interest, LAD territory, and we took a normal circumflex on the right part of the image, okay? And we consider that to be the closest to the FFR definition, which is FFR gives you an idea of the maximal achievable flow in that region divided by what that flow would be in the absence of stenosis. And so the results are actually on the left part of the slide. That's the main results. Not too bad. We have a nice relationship, curvilinear relationship. But most importantly, most cases are well classified if you compare the FFR value on the horizontal axis with the threshold at 0.8 with the absolute PET, be it expressed as a relative quantity, because that's the only way to compare the two. So that's one study showing good relationship. The other one is more recent, also used the same tracer, by the way, which is O15 labeled water. And here they took another perspective. They said, listen, we're going to measure two things with PET, absolute myocardial blood flow and the myocardial perfusion reserve, which is the ratio of resting, absolute, okay, it's maximum flow divided by resting. So it's the coronary flow reserve or myocardial flow reserve. They decided about cutoffs based on PET data, and then they looked at the classification rates from FFR, IFR, and PDPA in the same patients. So this is more like a threshold positive negative analysis, and you can apply the usual diagnostic metrics, sensitivity, specificity, etc. And that's what's shown on panel A. You have the area under the curve. Panel B, you have the individual values for sensitivity, specificity, diagnostic accuracy. And you have FFR, IFR, and PDPA. And actually, it is pretty good. So classification rates of these indices that you derive in the cath lab from two pressures is remarkably consistent with what you measure when you compute flow in absolute terms from the gold standard, which is PET. So I think it's done, but it's good to keep it in our mind. And yes, it is possible to get very critical information about flow from two pressures in the cath lab. Another question you had is, what is the range of heart rate, blood pressure, contractility where the measurements are valuable? And we did that very early on, and that's the data. Left is heart rate, so we change heart rate with pacing between 80 and 110. In the middle, blood pressure. We changed it with nitroprusside, 79 to 100, mean blood pressure. And we also acted on contractility, where we had a smaller range of blood pressure, but still very significant different doses of dobutamine in the same patient, and measuring FFR in the same lesions under those different conditions. And I have to say, within this range, pretty good. So the key message is you don't have to worry too much within these physiological ranges with respect to heart rate, blood pressure, and contractility. Your FFR measurement is pretty much stable and valuable. Now, you could argue the range of heart rate is relatively limited. So I'd like to ask Mattia to tell us a bit, what would you anticipate if you had a patient with very high heart rate? What would happen?
Yeah, thank you, William. To answer your question, we have to think a little about to the basis of FFR. FFR derives from the mean PDPA ratio obtained from the whole cardiac cycle. And we know that the cardiac cycle, during the cardiac cycle, most of the flow is present during the diastole and not during the systole. So if we have a stenosis in the vessel, we can measure a pressure drop only during the diastole and not during the systole. When we have a pressure drop that is absent and the ratio PDPA tends to 1 during the systole. So if you can show the rest of the slide that represent what I just said, we can expect that at higher frequencies, higher health rate, higher is the systolic time of this cardiac cycle, and greater is the impact on the PDPA ratio by the systolic time that normally tend to 1. So at heart rate above 100, 110 beats per minute, we can expect a greater influence of the systolic phase on the PDPA ratio that tends to 1, and so we can expect a higher FFR, a more normal FFR for a given stenosis.
Great. So our experiments in humans only went up to 110. And in fact, if you go beyond that, you may start to see the phenomenon that you anticipate. So we have to be a bit careful about that, although there is probably very few situations where you will measure FFR in a patient with a heart rate above 140, something like that. We talked about FFR. What about IFR? No study so far has investigated the influence of heart rate or blood pressure variations on IFR measurements. What we do know, what you experience, of course, all the time, is that you're supposed to be in stable resting conditions. So any injections, particularly contrast or prior injection of adenosine, can have an impact on resting flow for a long time after it has been delivered. So for IFR, you really have to be sure that you are in true resting low resting level, resting flow conditions. So Mattia, another point that has been raised very often is the issue of the venous pressure or the diastolic pressures that are opposing flow. What's the impact there with respect to FFR, IFR?
Well, we can expect that a higher left ventricular diastolic pressure can lead to a functional microvascular dysfunction that can lead to a blunted vasodilatory ability. So in this case, the PD, the pressure, the distal pressure, can be higher than normal, and so also the FFR, that is the ratio PD of the PDPA, can be expected higher, so falsely normal. And this can be expected also in the case of IFR measurements, where we have, however, if we have a higher left ventricle diastolic pressure, we have also an intracoronary diastolic pressure increased. And that is the exact pressure that we measure during the late diastole, that is the wave-free period where we measure the IFR. So in the same way, we can have also we can expect an higher IFR that is falsely normal.
Yeah, but let me qualify this. Falsely normal, what does it mean? The measurement is the measurement, right? What it says is that for a given stenosis, the FFR will be higher than you anticipate, correct? So the FFR underestimates, because of the increased left ventricular diastolic pressure, underestimates the hemodynamic significance of the stenosis. And that's true for FFR and IFR. Now, in the clinic, is this really relevant, Mattia? Does it matter?
I think not, because as showed by this study by Leonardi that addressed the FFR and not the IFR, we can observe that there is an increase for the FFR for higher left ventricle and diastolic pressures. But as you can see, the increase is just mild, just 0.008 for every 1 millimeter of mercury increase of left ventricle and diastolic pressures. So the impact on the clinical relevance of this increase is doesn't matter, and so we can just know it for our knowledge, but it doesn't impact in any way, in my opinion, the clinical routine, the clinical practice.
Yeah, and that's a common theme with FFR, IFR. You can always find physiological differences that it's not 100% correct, but in a pragmatic way, in the range of pressures that we're working with in the patient, it doesn't really matter here. Look, FFR unit increases by 0.008 for 1 millimeter. So if you have a 10 millimeter increase in diastolic pressure, it will only be still an FFR increase of 0.08. So really, it doesn't matter much. Maybe there is a couple situations where it can matter, particularly if you're looking at borderline stenosis. Now, in the practice, we don't have left ventricular diastolic pressures when we're measuring FFR. So what we're using is, as a surrogate, is the right atrial pressure, correct? So what is known about that? I have to remind you one thing that we didn't address last time. The very first formula for FFR was PD minus venous pressure, and venous pressure was approximated by right atrial pressure divided by aortic pressure minus the right atrial pressure. Okay, so it was actually PD minus PV divided by PA minus PV. And then Pels and De Bruyn looked at it and they said, listen, do we really need to stick the vein, advance a catheter in the right atrium? This is not going to work. So does it matter pragmatically? And their conclusion was, it doesn't matter much by and large. Okay, let's take an example. These are the numbers there on the right part of the slide. Everything is measured during maximal hyperemia. Okay, aortic pressure 100, diastolic pressure 81. We are at the borderline. Okay, the way we measure it today is two pressures, distal and proximal. If you want to be more correct, you include the right atrial pressure as a surrogate for the myocardial venous pressure. And if it's low, which is the case in 90% of the patients you're looking at, say 2 millimeters, it doesn't really matter much. Okay, it's 81 minus 2 divided by 100 minus 2, that is still 0.81. But if you have a larger, much larger increase of right atrial pressure, then it can matter. For instance, that's the extreme case. Suppose you have a right atrial pressure of 24, okay, then same story. If you don't measure right atrial pressure, you're not cognizant of this, you actually underestimate the severity of the stenosis in terms of its hemodynamic behavior. And in fact, you're going from normal to abnormal. Which patient in your practice could this be the case? It would have to be a chronic heart failure patient who can lie flat even though he has very high right atrial pressure because he's used to it, very poor LV. So if you have a patient like that with a lesion where you wonder whether it's significant, keep the story of the right atrial pressure in mind. But by and large, in a pragmatic way, in the vast majority of patients you're studying, it's not gonna matter. Okay, I hope I made that point clear. So here again, very high increase in right atrial pressure or back pressure to the flow reduces the FFR myocardial. That was the definition when you incorporate right atrial pressure. Well, if you just measure the two pressures, it will not, you will miss that point. So you had another question, and here, you know, we were a bit surprised. We had to look for it. So Mattia did all the research on it, looked at the literature, and the question is, what's the role of anemia? So what did you find, Mattia?
Actually, William, I haven't found anything about it because there are some studies, but they always compared anemia with the coronary flow, but not with the pressure-derived indexes like FFR and IFR. So what we have found is just that the anemia, as we know, increased the cardiac output, and as a result, we have an increased resting coronary flow, but with the hyperemic coronary flow is the same, is not increased in case of anemia. So what we can expect, just thinking about it, is that if the hyperemic flow doesn't change, we shouldn't expect any FFR change, while we should expect a change in the IFR measurement because there is an increased resting coronary flow. And don't forget to remind us that there are other conditions like anemia that increase the resting cardiac output, and so can have the same effect on pressure-derived index of anemia, like sepsis, chronic lung disease, cirrhosis, and so on. So keep it in mind, because you can have often patients with these kind of clinical conditions.
Excellent. Now this you had in your list. That's also a difficult one. What about plaque composition? Because we only talk about hemodynamics of the stenosis, and we know that the content of the wall is important. So it is pretty obvious that if you have a high-risk plaque, for instance, because high lipid content, that plaque can cause death and MI, okay? And for a given stenosis, the FFR will be or normal or abnormal, doesn't matter. The FFR, you would think, is not affected by plaque composition. That was my idea. Now, if we want to describe what's out there in the literature, we have to admit that there's a number of colleagues who have described an interaction between the FFR and the plaque composition, particularly Dr. Narula. And they have data suggesting that if you have a large necrotic core, okay, for the same stenosis severity, you might actually have an more abnormal FFR than with fibrotic plaques. I'm giving it to you for what it means. I personally don't understand it, but that's certainly an area where we have a gap in knowledge. So by and large, I think we really focus on what's happening from the hemodynamic point of view inside the lumen, but there is the possibility, and more research is needed on the interaction between plaque composition and hemodynamic parameters. We can take a little breath here now, because we've actually already covered about half. Maybe Azim or Tony, is there any burning question or discussion point that you or colleagues on the call would like to raise at this point?
Yeah, there was one or two. Maybe I'll start. You mentioned, Mattia, the impact of tachycardia, which makes a lot of sense, and the component, the diastolic and systolic component. Is there any impact from having arrhythmias? So a patient who either has atrial fibrillation or, say, a patient who is in ventricular bigeminy, can that impact?
Well, I think so, because it's important also to have a very stable pressure traces on the monitor when you measure FFR and IFR. So if we have any arrhythmias, in particular irregular arrhythmias like atrial fibrillation, we can expect to have abnormal measures, or at least impaired measures. So it should be better not to measure FFR or IFR.
Well, I suppose AFib is okay if it's reasonably controlled. Don't forget that we are not measuring one beat. Depending on the setting of your machine, you're going to average the measurements on 3 to 5, for instance, for FFR beats. So there is already some averaging. By Gemini, I'm not sure what we can conclude from that measurement, I would say. And perhaps a little atropine or something, or a way, if the bigeminy is associated with bradycardia, maybe you need to do something about it to try to have a stable heart rate and at least be able to measure during 3 or 5 consecutive normal beats.
Okay, great. Tony?
Just one of the questions from the chat was, how about the effect of low blood pressure with and without hemodynamic support, that is impeller, on IFR and FFR?
Oh. Wow, that's a tough question, and that I have to say I cannot address because maybe it has been looked at. Now, tell me, Tony, what is the clinical situation that you're referring to? You have a patient cardiogenic shock, middle of the night. You've opened the culprit artery, and there is another one, non-culprit, that you'd like to know whether it's significant or not?
Yeah, that's exactly
That's it. Yeah.
the situation.
Yeah. Okay. I think that's a very relevant question, increasingly relevant, I suppose, because you see more and more of those patients. So that would be a good idea to look at. Look at this. First of all, reflect on it from a theoretical perspective, and then maybe try to do some measurements. Yeah.
Okay.
Very good point. Gap in knowledge, at least in my knowledge. Shall we move on?
Tony, was there any other burning questions?
I think we can just move on for now.
Okay,
Yeah.
great.
Now, the hot topic, and I hope we're going to spend a little time on it because I think it's really important, and it also shows what's the trade-off between being highly scientific from physiology viewpoint and being pragmatic. So I'm going to hand it over to Mattia. What is your thinking? How will tandem and or diffuse lesions, we start with tandem lesions, impact the measurements? Tell us.
Well, William, let me show one example. If we have a single stenosis in one vessel and we measure maybe the PDPA and we find PDPA of 0.5 because we have a distal pressure of 50 and an aortic pressure of 100, and we imagine to have a second stenosis distal to the proximal one, how can it be the new PD in the middle between the two stenosis? I expected that during the hyperemia, this pressure could be higher than the normal pressure we can find without the distal stenosis, and this could impact both the PDPA ratio for the proximal and for the distal stenosis, because in this case, if the PD1, the new PD, is higher than the 50, we can expect a falsely normal FFR for the proximal lesion, I mean a higher FFR because of the higher PD, and a falsely abnormal FFR for the distal lesion because the PD is higher than the expected. So it was also postulated that for IFR this is not it is not the same story, because the resting condition may offer a more realistic pressure drop between the two lesions across the two tandem lesions. So IFR could be more reliable than FFR in this case. But can you please go to the next slide? Yes. Some authors confirmed this theory, showing this scheme where we have exactly the situation that I just described. So we can have an underestimation of the functional significance of the stenosis A, the proximal stenosis, and an overestimation of the functional significance of the distal stenosis if measured with the normal FFR. There is a way to measure the FFR for the tandem lesions, considering taking into account the interaction between the two stenosis, but it needs for a wedge pressure that is measured with an inflation, a balloon inflation after the between the two stenosis. It is not really practical. So IFR in these cases can overcome these obstacles and offer a better and easier way to measure the functional significance of tandem stenosis.
Yeah, let me make one comment here. I think there is 6 or 7 papers describing different methods on how you can know exactly what's the hemodynamic significance of A versus B. The point I'd like to make is, does it really matter? These models all assume that you have normal vessel, lesion A, normal vessel, lesion B, normal vessel. When you have a tandem lesion, it's very likely that the vessel will be diffusely diseased. So does it really matter? What does matter? And that's what we're coming to in the next. So these formulas are very interesting scientifically. I'm not sure they're very useful in practice. So how do you do then in practice? This is an example. We start on the left, upper left, with this diffuse disease right coronary artery with 2 consecutive lesions, okay? The overall FFR, 0.34, that's extremely low. That's extremely low. You have the curves over there. And if you do the pullback, that's the right upper, okay? You give adenosine, you pull back rather quickly, and you can see that there is, across the proximal lesion, a very, very significant drop, right? So the pragmatic way that has been proposed, you take one. And you start maybe with the most severe. Now, in the past, we had issues crossing with the stents, okay? It sometimes, if you stent proximal first, it might be very difficult to reach the distal. I may sound like a very old man now because that's not the sort of issues that you're dealing with, yeah, right? So you can select the one that looks the most severe to you. You treat it to the best of your capacity, and then you measure again, okay? And that measurement will be a more adequate measurement of the hemodynamic significance of the second one. Look down there, down left, okay? We have clearly a significant residual gradient on the proximal stenosis there, okay? So you treat the second one equally well. 2 stents. Now, at the end, and that's my point, when the 2 stenosis are treated, 0.87, it's okay, but it's not perfect. Meaning what I just told you, what matters is to correct and try to restore the conductance of the epicardial vessel to the highest possible level, which is 1, no obstacle at all. And in many cases, it will not be possible because there is diffuse disease, like in this case, you have diffuse disease as shown during pullback from the gradual increase of the distal to the proximal when you go towards the coronary ostium. So that's the point that I wanted to make about the tandem versus diffuse. So the pragmatic suggestions are, you first measure the overall because that's your target. Your target is not the stenosis. Your target is the epicardial vessel because that's what we can access to. You do the hyperemia, you do the pullback, you identify all the segments with pressure drop, you stent the most severe spots first, and then you measure at the end. Okay? Now, what we have been missing for decades is co-registration of the pressure tracing with the anatomy. And fortunately, we have that now. And it's available both for IFR and FFR. And that's very, very critically important. And if you remember just one message from this one, what matters is not anatomy alone, it's not physiology alone, it's both and co-registered, because then you can really identify which are the segments that don't have normal conductance and how you can fix them, if they're fixable with stents. Drugs, of course, and secondary prevention will play a role as well. So I was alluding to the possibility of co-registration, and Mattia explained to us in this case how it will impact the practice. And I think you're going to use IFR in this case.
Yeah, this is a very interesting example of the co-registration, William, using the IFR, and maybe the people attending this meeting are already using this tool in their cath labs. Practically, this tool allows to co-registrate the angiography, the fluoroscopy, and the IFR measurements during the pullback. So we can see that in the picture A, the software represents with different numbers of points the pressure drops across the multiple stenosis that this vessel presents. And each point represents a drop of in the pressure and the PDPA ratio of the IFR of 0.003. So more are these points, more is the pressure drop across the lesions. And you should start to treat the lesion with the higher numbers of these points. That in this case is number 2 and then number 4. And so you can easily address the most important, functional important lesions just with the pullback and co-registrating the fluoroscopy during the angiography.
Exactly, and that is what matters, because what matters for patient outcome is the conductance of the vessel you've treated when they leave the cath lab. And I can't stop showing this slide. This is from Barbato's work, I think, or Lee. You see the fractional flow reserve at the end of the case. You know, you say to the patient, fantastic, good result. We know that in a number of cases, the final FFR will not be that good. It may even be below 0.9, in this case, below 0.88. The event rates, particularly need for repeat intervention, increase dramatically if the patient leaves the cath lab with a poor functional result. And the study on the right shows the 3-year TVR between those patients. This is from DK Crush 7. Actually, you see there is a very significant difference in TVR. And actually, in that series, they have even shown difference in mortality. It's the only study that shows that. So remember, it's nice to do complicated formulas to calculate A versus B, but what matters for the patient is you consider the entire vessel, okay? And you do your best with that vessel to increase the conductance as close as possible to normal volume. A bit along the same lines, but different context, it's the typical situation of the occluded right, chronic coronary occlusion, and a mild stenosis on the LAD. And the question comes very often, okay, do we treat the LAD or not? Mattia, tell us how to react to that clinical situation.
So bearing in mind that the coronary flow is proportional to the downstream myocardial mass that a vessel has to supply, we can expect that if we have, for example, an LAD stenosis that gives also collaterals, good collaterals to the right coronary artery myocardium in presence of a CTO of the right coronary artery, we expect an increased resting and hyperemic coronary flow in this vessel, in the LAD in this case. And for a given stenosis, compared to a situation without these collaterals, we can expect a lower IFR and FFR value on the basis of the stenosis severity because of this increased myocardium that is supplied by the vessel in question.
Exactly. So if you have an LAD, the myocardium subtended by that stenosis might be double what it normally is because it takes care of itself and the entire right coronary distribution. So therefore, you will see a mild stenosis and very severely depressed FFR or IFR. So thank you for that. Now, that is a situation of that patient, of course. What about the situation here? You have an example of it actually in the collateral donor vessel. How does it change after CTO? You want to explain this, Mattia? Please go on.
Yeah, of course. In the left of the screen, you can see an FFR example, while in the right, you can see an IFR example. But the concept is exactly the same. We have a stenotic LAD that is giving good collaterals to the territory of the RCA and chronically occluded RCA. Before the PCI of the CTO, we have a positive FFR, an abnormal FFR, and an abnormal IFR in the LAD, 0.75 and 0.72. And after the stenting of RCA, of course, the myocardium that is supplied, but the LAD is different, is less, and the FFR becomes negative, and also the IFR, or even if borderline in this case. But keep in mind that the increase in the FFR value is slower than the increase in the IFR value. Indeed, it was demonstrated that only after 3 or 4 months from the PCI of the CTO, you can measure an higher FFR than that measured before the PCI.
Okay, that's clear. Now, one more topic, maybe it's the one that you've worked a lot on and that I still, have many questions about. It is the assessment of CAD severity in patients who have coronary disease and aortic stenosis, obviously, in the context of TAVI. So tell us about the theory and how we should, what do we know as of today?
Yeah, thank you. What we have hypothesized before our studies is that the presence of the severe aortic stenosis can impact both the IFR and the FFR. Why? Firstly, because we have a lower cardiac output, and so we expect a lower aortic pressure. So the denominator of the PDPA ratio is lower. And secondly, because we have a lot of consequences derived from the presence of aortic stenosis on the myocardium. In premise, we have left ventricle hypertrophy, we have fibrosis, and all these consequences led to a higher left ventricle and diastolic pressure, and also a blunted vasodilatory ability that increase the back pressure, the distal pressure over the stenosis. So we can expect that the FFR is falsely normal for a given stenosis, but we can also expect that after several months after the replacement of the valve, we have a left ventricle remodeling with a lower left ventricle and diastolic pressure. And so the FFR can become the FFR values can become more reliable and lower than those measured before the valve replacement. For the IFR, the story is opposite, because with the left ventricle hypertrophy, we have an increased resting coronary flow. So that's the same story of the anemia, and we can expect an abnormal IFR, so a more positive FFR than the result given by the FFR in the same moment and for the same stenosis.
Okay, so that's what you expect, and you've done many
Yes.
patients. What have you observed?
This is firstly an example of one of our patients where we can see exactly what I have just explained. Before the TAVI, we have a proximal LAD mildly, a stenotic proximal LAD with a positive FFR and a negative FFR. And immediately after the TAVI, we have still a positive FFR and a negative FFR, slightly lower than the previous value.
Yeah, but, so positive, you mean preserved, normal?
Yeah, preserved, yes, normal, and abnormal IFR. So for the same stenosis, we don't know if we have to do PCI or not, because it depends on our trust in the IFR instead of FFR. So when should we do PCI in that case? Our studies that are retrospective studies, so with all the limitation of the retrospective studies, we observed that the IFR tends to be abnormal and the FFR tends to be falsely normal for a given stenosis, as I just showed you. Immediately after TAVI, the FFR tends to be lower because of the increase of the aortic pressure, while the IFR shows an erratic individual variations without any predictable trend. After TAVI at follow-up after 6-12 months, again, the IFR shows an erratic individual variation. We didn't find any, we haven't found any predictable trends about its behavior. While for the FFR, we saw that it remained stable over time if it was strongly normal to baseline. I mean above 0.85. While if the FFR at baseline was borderline between the values 0.75 and 0.85, it tends to worsen during over the time, and you can find an abnormal FFR after 1 year from TAVI that was normal prior to TAVI. So when perform PCI in these cases, when the baseline IFR or FFR is abnormal, and if you have a borderline value or discordant values between FFR, IFR, or normal values, you should reassess the stenosis after at least 6 months with the FFR and rely on FFR then IFR.
Thank you. Now, Tony and Azim, I'm conscious of time. What do you want to do? Address questions or maybe select one of those topics for the few minutes that are left to us?
I'll let Tony speak as well, but in my opinion, I'm learning so much. This has really been a true masterclass in some very challenging topics, William. So I'd love for you to carry on, to be quite honest. Tony, what do you think?
Yeah, I agree. I think we should just go on. I think the next couple of dot points are actually will be quite useful. So
good.
Yeah.
In any case, if you have questions, we're more than happy to address them, as I said, through emails or any of the social interaction media after the talk or during the weekend.
Thank you.
Left main. Well, what's in a name? The lesion can be in the proximal or mid shaft, but of course, as you know, it is very often affecting the bifurcation and the distal vessels. So colleagues have looked at both FFR and IFR in left main lesions, okay? And of course, if you take the example of the left, it's not unusual to have an abnormal FFR in the LAD and a preserved in the circ, depending on the size of the myocardium that is disturbed by this left main coronary artery. And of course, it is the abnormal value in the LAD that will tell you about the indication for the procedure. Okay, so this graph here shows how to do the interpretation depending on the lesion location. I have to say myself, I'm not a big fan of physiology and left main, except perhaps for the situation on the left. Otherwise, I think, you know, imaging is probably more important, except perhaps at the end of the case where you want to make sure that the physiology is restored. The situation on the left I like because it shows again the impact of the amount of myocardium that depends on a given stenosis, how it affects the FFR at least, less so the IFR. I think what is important is the issue of deferral. You know, if you're using physiology in the left main, you have a mild lesion, and what about preserved FFR and IFR? Do you leave it? Do you defer it just like you would do for another vessel? Well, these are the data that suggest that yes, if it's non-hemodynamically significant, you shouldn't treat it. And the graph on the left is for FFR, the graph on the right is for IFR. You have two curves and you can't dissociate them one from the other. Okay, what is it? One curve are patients who have been stented because the FFR was abnormal, and the other curves are patients who have been deferred because the left main stenosis showed preserved physiology, and actually there is no impact on MACE-free survival based on the deferral, whether it's based on FFR and IFR. So I think that's important data. Again, this is not randomized. It will never be randomized, obviously, but I think it is important data, even though the numbers, as you can see, are relatively small. And that's why I said from the onset, you know, perhaps we shouldn't weigh too heavily on physiology for decisions in left main intervention. But that's my viewpoint. The other, I mean, this brings us to bifurcation, and I'm handing over to Mattia. Same thing from my perspective, you know, bifurcation, you just have to make sure that the anatomy is right, but there is the issue of the side branch, of course. So how can FFR, IFR help there? Mattia, your turn.
Yes, bifurcation is another very debated topic about functional assessment, in particular for the role of the functional assessment in the side branch, because if you can show the rest of the slide, please. Side branch is, of course, somehow impaired from the presence by the presence of the stenosis also in the main branch. So you can expect that assessing FFR or IFR in the side branch in presence still of the stenosis in the main branch, the value is more abnormal, is overestimated, so that it's not a good idea to assess the functional significance of a side branch stenosis before stenting the main branch. So FFR and IFR is in true bifurcation can be measured in the main branch, and it is reliable. I expect it is reliable, but in the side branch it's better to wait after the stenting of the main branch.
Yeah, which creates a little bit of a practical issue because you like to have a wire down there, and I'm always a bit nervous about jailing a pressure wire. So that's a practical issue that you might consider in terms of making the procedure more complicated than it should be. Now, on the next slide, I think you have a couple of nice examples.
Yeah, the first one on the left of the screen is regards the main branch involvement. We have a stenosis of the main branch regardless of the side branch involvement, and the FFR in this case is positive, it's abnormal, so it's reliable, and you can do PCI based on this functional value. But if you have an isolated side branch stenosis, I mean a Medina 001, you can assess the functional significance of the side branch in absence of any involvement of the main branch, and it is reliable, and it was also demonstrated by some studies. But in the case, as I said previously, we have both the branches involved. You have to stent before the main branch, and then you can reassess the side branch with the FFR or IFR.
Now, I love this case because it is one where you have clearly a mismatch between the apparent stenosis severity, at least in this view, and the functionality, which is preserved. And sometimes this irritates colleagues because they say, look, tight stenosis, and look at the FFR. And I think what the colleagues from the European Bifurcation Club have nicely shown is that you have these images, slit-like stenosis, that heavily depend on the projection. And the reason is that the cross-section of the ostium is not circular. It is elliptical. And that explains why the dimension is large enough to allow a preserved FFR. Okay, so it is an issue of proper angiographic projection that explains why you have a preserved FFR here. In another view, it would appear normal. And this phenomenon is more apparent with a smaller angle. The bifurcation angle here is around 45%, something like that. With these low bifurcation angles, you have more and more elliptical ostium of the side branch. While if you have a 90-degree side branch, then it will be more like round, and this effect will not be apparent. So don't be fooled by angiography. Combine both. This case is one more complicated, Mattia, where you have both involved, or it's another example where you can use the FFR and the side branch to decide whether or not something needs to be done about this apparent osteal stenosis. Right. We can finish in 1 minute the bypass conduits. This slide is about Lima and Rima. Long vessel, okay? Not very large, particularly early after surgery. After months, it will double its volume. Is this vessel, is this graft an obstacle to flow? Because on average, its diameter is much smaller than the diameter of a vein graft. Absolutely not. You see, the FFR, the maximal hyperemia in a lima or a rima that is normal, way above 9, okay? So no significant obstacle to flow in those grafts. That's number one. Number two, what can we do with FFR, IFR in bypass conduits? The thresholds are about the same. This is, recommendation from Nico Pines, I think, that you can use it. He recommends to have the distal wire, the pressure sensor, in the coronary artery if you use it. My experience, and I think we touched upon it last time, and I think Azim agreed, in vein grafts, FFR is not that helpful. First of all, it's very difficult to have an abnormal measurement because even with stenotics, still the residual lumen is okay. And the problems are not so much hemodynamic related. The problems are related to thrombosis. And then the next point is, can we use FFR or IFR to tell the surgeon this vessel needs or doesn't need to be grafted? Okay. One small study, Graffiti by Emanuele Barbato, showed no impact on graft patency at 1 year. Okay, was a bit surprising. And then there is this other study, I think that's from Gliner, that shows that if you do FFR guidance, you have better outcomes, but it's a relatively small study. So I trust you will agree with me, Mattia, that there is some suggestion that we may use physiology to help surgeons identify which arteries to graft, but there is also resistance to that phenomenon because the mechanism by which CABG works is by adding additional conduits. So I think the issue is not solved yet. We have a large trial ongoing since a long time, it's FAME3, but that is comparing CABG driven by anatomy versus PCI driven by anatomy plus function. That's FAME3. We should have the results pretty soon. After many years of patient inclusion, this will tell us whether the CABG procedure needs to be refined by physiology in case there is non-inferiority with PCI guided by physiology and anatomy. So I'll stop here. And I thank you for the opportunity. Again, we remain available. We got a couple ideas of what needs to be done, some gaps in knowledge. Please remember, you have this artery, it's your artery, yeah? You have to bring the conductance of that vessel to a level that is as near as normal as possible. And to do so, you integrate anatomy and function. And the only way to do this properly is to have co-registration. Thanks again, and I'm handing over to you, Tony and Azim.
I'm gonna pass it on to Tony. You answered a lot of my questions, but I left Tony. You go ahead.
Yes, there was actually one question from the chat that was just popped up. So, can we use FFR/IFR measurements for stenosis proximal to a myocardial bridge?
Yes, that we had it was not on the list of the topics, and we had prepared it. I don't think I can pull the slide now. Send me send me your email and we'll give you the answer. I mean, you're making it complicated because you have the bridge and the stenosis. Even the bridge is very interesting physiology, and there is lots of very good data on that available now. So we'll address that, take it offline if you agree.
Okay, perfect. We'll send that question to you via email. Tony, anything else burning?
There's really not much in the chat, but just very quickly. So you've talked about doing FFR down the side branch and stenting the side branch, but I think if there's TIMI3 flow down that side branch, do we really need to do FFR and consider stenting it and just not leave it as it is?
Yeah, with what we know now from the cases where it was measured, I would agree with you. The problem we have had in the past is those, the main branch is okay, and the ostium of your diagonal is pinched. Should you treat it? We've learned now from physiology that in most cases, that in fact is not a true representation of reality, and that FFR is preserved. And this has given a lot of confidence to provisional stenting, leaving the branch like it is. Yeah, I would agree with you. As you know, I think that the future of physiology is image-based. It's not wire-based. I think it is image-based. And for instance, in a situation like that one, we don't have good image-based solutions yet. Side branch, for instance, but that would be supreme if you would have from your angiogram, if you would have that information. No need for a wire. It's a new wire, you have to cross through cells. I mean, what matters really is to have the anatomy of the bifurcation right. And we've learned from the colleagues who have done the measurements that in those cases, it is okay. So I would certainly not recommend routine use of FFR in bifurcation stenting, but that's my personal bias.
William, maybe a last question before we let you go. I mean, just because you mentioned it, image-based FFR, I mean, what do you think is really going to move the bar? Is it going to be angio-based FFR? Or is it going to be something like OCT-based FFR, where you actually really get the anatomy plus the significance of lesions in one?
Thank you very much. You know, it's a topic that's very close to my heart. I really think that we ought to quantify the physiology at the end of the case, just like we perform good angiograms. So for daily practice, I don't think that OCT and IVUS are going to be doable. If you have it, great. If you have it on the table, great. But it's not going to be used in the majority of patients. So image-based, CT in the first place for the diagnostic procedure, and angio-based for the interventional procedures, I think that's the way to go. If it's not as accurate as OFR, which is FFR derived from OCT, or UFR, which is FFR derived from IVUS. The image-based is not as accurate as soon as you have a stent.
Okay.
But it's good enough to tell us about the conductance of the vessel we worry about. And if it's high enough, you're done. If it's abnormal, then you need imaging. Where is the obstacle? Is it in the stent? Is it outside the stent, or both? And that gives you an opportunity to compute again the FFR from the OCT, because you will need OCT to fix it. So I think it will help us to isolate a number of cases, probably up to 1/3 or maybe 1/5 of the cases, where the image-based final FFR is not going to be okay, and you'll need imaging to fix it.
Right.
I mean, that's what I anticipate, but of course you need to do the trials to show that this is the right way to go, and do the health economics.
Yeah. I think that's a great place to stop with a look to what could be into the future. If you agree, Tony?
Yeah.
Tony, thanks for joining us. William and Mattia, thank you so much. This may not have been as interactive as you'd hoped with questions, but I can tell you we were all, it goes back to what you taught me, William, about being engaged, and engagement and action are very different. I think we were all extremely engaged and listening and learning, and that's why maybe, you know, we didn't stop for too many questions. I certainly was following every word and every slide. Thank you so much. I learned so much this morning.
Thank you.
Thank you very much. Thank you, Mattia. Thank you very much. Well done.
Thank you, everyone.
Thank you all. Keep safe. Keep safe.
Okay.
You're doing a great job.
Okay. Talk to you soon.